Hi, this is Dr. Fox. Let's talk about lymphatic organs. In this video, we'll distinguish between both primary and secondary lymphatic organs and tissues. We'll also describe the locations and functions of red bone marrow, the thymus, lymph nodes, lymphatic nodules, and the spleen. We'll talk about the location, constituents, and functions of Waldeyer's ring, and we'll discuss tonsillitis, lymphadenopathy, and metastasis. So let's review our primary and secondary lymphatic organs and tissues. Primary lymphatic organs are organs which have stem cell mitosis as well as immunocompetence. So we have the stem cells for lymphocytes, those lymphoid stem cells dividing, and the lymphocytes themselves learning how to destroy pathogens and not destroy self. So these are our red bone marrow, our hematopoietic connective tissue, which is found at the ends of long bones or within flat bones, and the thymus, which is found in the anterior mediastinum, just anterior to the pericardium. Our secondary lymphatic organs and tissues are places that host immune responses. These include lymph nodes, which are lymphatic organs, and lymph nodules, which are just tissues. Lymphatic nodules are not organs because they lack a capsule and they don't have any underlying architecture. They're just a mass of tissue with no organization. The other secondary lymphatic organ is the spleen. The spleen is the largest mass of lymphatic tissue organized into an organ, and it's found in the left upper quadrant of the abdominal cavity. So let's take a look at the hematopoietic connective tissue, or the red bone marrow, a rose by any other name. So it already has two names that you're aware of. We also sometimes refer to this as myeloid tissue. This is very abundant in both flat bones and the ends of long bones, so the epiphyses and metaphyses of long bones. And it basically is a large collection of both myeloid and lymphoid stem cells. So the myeloid stem cells are going to give rise to erythrocytes or red blood cells, thrombocytes or platelets, granular leukocytes, and monocytes, which can then become macrophages. The lymphoid stem cells are going to give rise to the B cells and the T cells. T cells because they mature in the thymus, so they are thymocytes. Speaking of which, the thymus is a very interesting organ. It's found in the mediastinum, specifically the anterior mediastinum. It is bilobed, so we can see there's one lobe there and the other lobe there, and capsulated. There are trabeculae within, and so the trabeculae are going to divide the thymus into lobules, where you can find collections of both cortex and medulla. Cortex is generally the outer portions of organs, so it derives its name from the Latin for bark. So bark is found on the outside of a tree, whereas medulla is something that's deeper, usually the marrow of something. And so the cortex is superficial in an organ and the medulla is deeper. Well, within both the cortex and the medulla, there is a process of T cell selection and maturation. And so we have to train T cells to, one, become reactive, and two, not become so reactive that they'll react against ourself. And so they go through this process of positive and negative selection. And the total outcome of which is that usually about 95 to 98% of potential T cells are going to be removed from circulation within the thymus before they can ever be released into the body. Now, the cortex is where positive selection occurs. Positive selection is making sure that these developing thymocytes can react to portions of the immune system. So they can latch hold of major histocompatibility complexes and become reactive to antigens. And then deeper within the medulla is where negative selection happens. And with negative selection, we make sure that that thymocyte isn't too reactive, that it would recognize our own cells and destroy that, or hence lead to autoimmune responses. Now, the thymus is a rather interesting organ in that it achieves its maximum size at puberty, and then it goes through a process of involution, whereby the organ itself slowly fibroses and turns into fat. And so here in this photograph, we can see thymic fat occupying the space previously that the thymus would occupy within the anterior mediastinum. We also have lymph nodes. Lymph nodes are bean-shaped organs that are capsular, so they have a capsule that surrounds them. Typically, they're found in groups that we give names to. With lymph nodes, there are afferent channels that feed into the lymph node. Afferent goes into, and then there's an efferent channel or vessel that leaves the lymph node at the hilum. So the hilum is an indentation of an organ that usually is going to host vessels in or out, but for a lymph node, the hilum is out only. It is efferent. So the lymph node has a rather complex architecture. There's a capsule, then a subcapsular space. The subcapsular space is going to surround both an outer cortex sinus and then an inner cortex sinus, and then those are going to surround medullary sinuses. All along the way, as lymph is moving through the lymph node, it travels through these sinuses. And in the outer cortex, that lymph is going to encounter B cells. In the inner cortex sinuses, that lymph will encounter both T cells and dendritic cells, which are specialized antigen-presenting cells. And then within the medullary sinuses, we'll find B cells and activated B cells, so the plasma cells, as well as macrophages. And so these lymph nodes are able to, both through B cells and T cells, mount immune responses. And if an immune response occurs within the lymph node, we could have lymphadenopathy, or an enlargement of that lymph node, as we'll subsequently see. We can contrast lymphatic nodules from lymph nodes in that lymphatic nodules lack a capsule. So they are acapsular and they lack any sort of architecture. They're just a mass of lymphatic tissue. Oftentimes, these masses of lymphatic nodules are called MALT. So MALT is short for mucosa associated lymphoid tissue. This is a mass of lymphatic tissue that hangs out at the lamina propria, so that basement membrane of mucous membranes, where it can come into contact with potential pathogens. This MALT tissue is very rich with lymphocytes as well as antigen-presenting cells. So we have all of the basic recipes for an immune response. It just needs the pathogen to present itself. Oftentimes, the MALT can be very specific to specific regions, and so we'll modify MALT to be more reflective of where that region is. So, for instance, aggravated lymphoid follicles can be present within the small intestine, specifically the ileum, and we refer to these as Peyer's patches but specifically we call them GALT. GALT is gut-associated lymphoid tissue. And what GALT is good at doing is, if a pathogen rubs itself through the Peyer's patches, that lymphoid tissue, specifically the B cells within the lymphoid tissue, can secrete specific IgA antibodies against that particular pathogen. So MALT is throughout our airways, throughout our digestive system, anywhere that we can have a pathogen encounter. Now we have a very specific set of lymphatic nodules that surrounds our aerodigestive pathway, so both the nasopharynx and the oropharynx, called Waldeier's ring, or Waldeier's ring of tonsils. So over here we can see aggregations of lymphoid tissue. So we have a pharyngeal tonsil in the nasopharynx. We have both palatine and lingual tonsils within the oropharynx. Over here we can see the palatine tonsils on either side of the oropharynx. And these are going to form a near complete ring around both the naso and oropharynx. So let's look at that now. So this is a pharyngeal ring of MALT. So here we have our pharyngeal tonsil, aka the adenoid. There are tubal tonsils associated with the openings of the eustachian tubes within the nasopharynx. Then we have the palatine tonsils. The palatine tonsils are the tonsils. Those are the ones that if you say that you've had your tonsils removed, that's what has been removed. And then the lingual tonsil on the surface of the tongue. So in all, anything that you breathe in, either through your nose or mouth, or bring in by means of eating or drinking through your mouth, encounters part or all of Waldeier's ring of tonsils, so that your body can immediately mount an immune response against it. So we have very early activation of B cells, converting them into plasma cells for the production of IgA antibodies that can then circulate throughout the body and destroy the pathogen as they encounter it. You may have yourself experienced tonsillitis or know of someone who has experienced tonsillitis. This image here is a photograph of someone with inflammation of the tonsils. And so you could even see the accumulation of white purulent fluid on the surface of the tonsils, another hallmark of tonsillitis. Tonsillitis is generally an issue of the palatine tonsils, although the adenoid can also become inflamed. There are a number of different etiologies that can lead to tonsillitis. Typically, tonsillitis is indicative of a viral infection, but also it can come from a group A strep infection. Mostly we just give supportive therapy, so time and fluids. If it comes from a group A strep infection, antibiotics may be prescribed. Someone who suffers from frequent tonsillitis, whereby it's obstructive to their airway, may seek the remedy of a tonsillectomy. Tonsillectomy is the removal and the cauterization of this tonsillar tissue so as to prevent recurrence. Next up, we have the spleen. The spleen is found in the left upper quadrant, also known as the left hypochondriac region. Hypo means below. Chondriac is the cartilage that connects the ribs. And this is the single largest mass of lymphoid tissue in the body. It's organized into an organ, and that organ has two distinct pulps to it, both a white pulp and a red pulp. So if we were to look at this on a much enlarged scale, we can see that white pulp surrounds the arterial portion of the organ, and this is where we'll have immune responses. So lymphocyte action occurs in the white pulp, whereas the red pulp surrounds the white pulp. And the red pulp is more important to the cardiovascular system. So we'll have erythrocytes being removed when they become defunct. Platelets can be stored or sequestered in the red pulp, and we also have the ability for hematopoiesis or hemopoiesis within the red pulp of the spleen. So dual duty, both lymphatic and cardiovascular functions for this particular organ. If you've ever had an infection that's led to a swelling or an enlargement of your lymph nodes, you've experienced lymphadenopathy. With lymphadenopathy, the lymph nodes have enlarged, generally due to some sort of infection. This enlargement is very common and it's very nonspecific, so there are a number of different etiologies that can lead to it, some concerning, some not at all concerning. The reaction might be generalized, meaning systemic throughout the body, or localized to a particular set of lymph nodes. If those lymph nodes are also or suffering inflammation, that is referred to specifically as lymphadenitis. That itis is indicative of an inflammation, and this is the most common type of lymphadenopathy. Lymphadenopathy, while is oftentimes indicative of a rather, benign infection, might also be indicative of a malignancy or a cancer. With lymphadenopathy that comes or is the result of a malignancy, generally these enlarged nodes are painless. So if you touch them, they don't hurt at all, and they are firm and fixed. And by that, I mean they're not squishy at all. They feel very hard, almost like a rock. So there's no give to them, and they're not mobile. Like a lymph node that is enlarged due to a virus or a bacterial infection is often tender, so it's painful and it's squishy. There's a little give to it, and it can roll about wherever it's located. Whereas a lymph node that has a malignancy within it doesn't hurt, it's rock hard, and it doesn't move. There are other characteristics to help distinguish between lymphadenopathies from rather benign versus more malignant sources, but they're really beyond the scope of this video. Now, a malignancy within a lymph node might be the result of a lymphoma, so Hodgkin's or non-Hodgkin's lymphoma, a cancer of the lymphatic tissue itself, or it may arrive there due to metastasis. So through lymphogenous or via the lymphatic system, metastatic illnesses like cancers may move, and they can take root within a lymph node and can then enlarge the lymph node and be a source of a malignancy, a secondary source of malignancy. There's also lymphangitis. With lymphangitis, the lymph vessels themselves become inflamed, and what you can see are streaks of red or inflammation, sometimes visible through the skin, that are heading towards collections of lymph nodes. Metastasis is the spread of a disease. Oftentimes we refer to metastasis in the context of cancers, and there are various ways in which a disease, or more specifically a cancer, can travel or spread through the body. The big three are transcelomic, which is actually a rather minor pathway. Transcelomic metastasis involves movement of cancer cells along membranes of cavities, so serous membranes like the peritoneum, the pleura, the pericardium, etc., metastatic cells can move and seed into new locations. But the two more popular routes are hematogenous and lymphogenous. Hematogenous metastasis is movement of the disease through the bloodstream, whereas lymphogenous metastasis is through the lymphatic system. More often than not, sarcomas, which are malignancies derived from tissues of the mesenchyme, are going to spread hematogenously, but also renal carcinomas. These are epithelial cancers that arise from the kidneys, will also spread hematogenously. Generally, the pattern of movement is through the veins. So typically, hematogenous metastasis is venous in pathway. Lymphogenous metastasis is through the lymphatic system. Generally, carcinomas, these are malignancies of epithelial tissues. So this is accepting renal carcinomas, but epithelial or carcinomas will move through the lymphatic system. And when they encounter lymph nodes, generally something that is painless, firm, fixed, and unilateral, meaning on one side but not the other, gives us a clue that maybe we're dealing with a metastatic lymphadenopathy versus a more benign lymphadenopathy. So we've discussed the primary and secondary lymphatic organs. We've discussed their locations and functions, the various locations and constituents and functions of Waldeyer's ring. We've discussed tonsillitis, lymphadenopathy, and metastasis. Thank you so much for your time, and I look forward to talking to you in the next video.